Are there, you touched on it a little bit, are there certain metrics, for example, that a patient needs to kind of be demonstrating XYZ before we're considering discharge?
So there are, they're not hard and fast. Again, each patient is that little bit different. They need to be tolerating oral medications. That's a big thing. Often patients are on a pain pump, so they're pressing, it's called a PCA or patient-controlled analgesia. They need to not be using that very much anymore so that we can transition them to oral because you cannot go home on IV pain medications. Again, zero pain is not realistic. There will be some. I mean, if there's zero, that's fantastic, but that's not typically what we expect postoperatively. So just making sure people are comfortable and familiar and really having that discussion of you can take this frequently. This you take regularly, standing. This is as needed. So just explaining those different things because this is our profession. But even if one of us is a patient, it's a very different thing when it's your own body. So intellectually you might understand it, but really kind of stepping back and making sure that the day to day and the hour by hour, people truly understand how to take care of themselves or the families can provide that care, especially with the pediatric population. But yeah, so oral medications, people need to be mobilizing, up and moving about. They don't need to be, doing 5K. We don't want them doing a 5K, but really they need to be able to be up and moving around. You heal better when you move. We want to make sure that they're passing gas, something as simple as that people are often amazed at the conversations that are had at the bedside. It's important. You don't need to have a bowel movement necessarily, but definitely passing gas, moving air through your bowels. That's something that we keep an eye on. So we will ask a lot of those questions that surprise some people. And really just that their pain is tolerable on the medications that they're taking by mouth so that we continue those same medications on discharge, on that transition. We don't stop things and send you home. We typically continue what you've required. Depending on some of the specifics of the surgery that Dr. Greenfield has done, some people end up on a steroid, some people end up on a non-steroidal anti-inflammatory, depending on some of the, again, the specific intraoperative things. So those are also important things to think of. Some patients tolerate those medications better than others. Sometimes we have to adjust the frequency at which we decrease the dose or the speed at which we decrease because steroids can cause, they're great for inflammation and for preventative measures, which is the purpose we use them after Chiari. But, they do all have side effects. Every medication has a good and a bad with it. So understanding and describing that, I think if people know what to expect, they're much better able to handle it and either verbalize that it's intolerable or, this is what they're experiencing and how can we help adjust that so that then Amanda's job is easier. Any outliers to kind of the protocol, if you will, communicating that to her. We had to change this medication. We had to order this lab, just different things. So that because we all deal with a lot of patients, so we don't automatically know everything about that person that was done. So we need to communicate with each other for that transition to be seamless. And reciprocally, Amanda or the outpatient team letting us know things. This patient's coming in and has X, Y, or Z. We need to be aware of that. It's very helpful, and it just helps make it smoother for the patient and their family ultimately.